sir. Good evening.
Good evening.
So I think I have a list of panelists. One second. So Dr. Ankur Vashne, are you there?
Yeah, hello, sir. I'm here.
So I think thank you for being there and thank you for taking out time today evening. And Dr. Jyoti, are you there? Dr. Jyoti, are you there?
Yes, sir. Ma'am is muted, sir.
So I think Dr. Biswas, Dr. Bivas Biswas, did he just leave or something? He was there for a minute. I just saw him leaving. Is he there or should I just leave it be? Garima, can you confirm, please? And Dr. Deni Gupta, obviously, we see him and he's been.
Yeah, I'm here.
So I think I'll start. It's a panel discussion on management of extensive stage small cell lung cancer. Thank you, Dr. Deni, and thank you, AstraZeneca, for this opportunity. And it's a very interesting panel here. It's a very interesting case here, rather. And moving forward, I think the way we're going to change, it's almost changed the way we manage our small cell lung cancers. And however, it's not there as yet. Yeah, the median survival is still year at max 1.5. We know that the small cell lung cancer, it tends to respond very well to the chemotherapy the first 3-4 months, and then it just springs back as if it just come back with a vengeance. Anyway, moving forward, we have a 62-year-old gentleman who has been a smoker, and it's very rare. It's almost impossible to find small cell in non-smokers. He is presented with increasing shortness of breath. There's hemoptysis. There's weight loss. And the patient's primary care physician has found there's a liver palpable, there's a massive enlargement, there is 3 to 4 times increase in there's a transaminases. The CT scan has been done at his first point of care, and that show a left lower lobe nodule, mediastinal lymph nodes are there, and there's a massive hepatomegaly. Somebody has done a biopsy, and it is also suggestive of a small cell histology. So moving forward, I'll start with you, Dr. Deni. What's your diagnostic workup? Would you want to repeat the biopsy from anywhere? Would you want to check for the mediastinal lymph nodes, or would you want to check from the liver? Well, how would you want to proceed forward with this?
So can you show me previous slide, Dr. Bhuvan? Yeah. So CT, I believe only CT chest was done.
Yes.
And right. So
yes.
And biopsy was done from which part?
So I think it's not mentioned, but I presume it must be from the liver. But anyway, let's presume that if no biopsy has been done, possibly what would be your
right. So if we are dealing with such type of case and a CT guided lung biopsy has been done, which is the usual scenario. So it is small cell lung cancer. So first of all, I would do the whole body PET CT scan for the staging workup along with brain MRI upfront, because we know that it is very common in small cell particularly, and even in non-small cell if they are a molecularly driven tumor. So I would be liking to do the PET CT scan and then straight away biopsy from the lung preferably. If it is not feasible, if it is a hilar mass lesion, so we can go for the bronchoscopy, and we can go for TB-LB sort of thing, transbronchial lung biopsy. And I think mediastinal staging I will not do. In those cases where there is already metastatic in the liver or bone metastasis or somewhere else. So if we are dealing with the earlier stage, and we are skeptical about the mediastinal staging, so there only I would go for the mediastinal, otherwise not. So these are the sequential workup.
So let's presume the liver is not there. No, moving forward, if it's only the lung lesions and the mediastinal nodes, would you want to would you want to stage the lymph nodes, especially considering there will be a limited stage? They're going to obviously include that in the radiation field. That's how the staging is defined, right? The veteran.
Yes, correct.
The
If we
veteran
are
staging
dealing
is
with,
a limited
if
stage.
clearly that is if it is imaging is showing the lung mass lesion and there is a mediastinal lymph node hilar either on the ipsilateral side or contralateral side. So then I would definitely like to confirm the pathological by bronchoscopic evaluation, or if as per the location, there I think there are some stations where bronchoscopic by bronchoscopy chest physician are not comfortable in sampling, then obviously mediastinal sampling will be required in those scenarios.
So the question which I want to raise, Dr. Vashnay, if you are there, generally in a non-small cell lung cancer, whenever you're defining your field of radiation, so I'm talking about a multi-station N2. So if it's a non-small cell lung cancer, when you're defining your field of radiation, you want to do a EBUS and you want to stage your lymph nodes so that you can map your radiation field and give a radiation according to the nodes involved. There's a 25% plus and there's 25% minus. The nodes which appear positive on the PET are negative, 1 in 4, and then the one which don't appear on the PET are positive 1 in 4. So what I'm saying is, does that same rule applies to your clinical practice in small cell, or do you generally not stage a patient?
So generally, small cell, I find a very limited subset with limited stage. Maximum, they are usually metastatic only. But if yes, if we found a stage 3 patient coming to and planned for CTRT, then we follow the same concept.
So what you do is you generally map the mediastinal nodes.
Map the mediastinal nodes.
Interesting. Anyway, so I think because as far as this thing is concerned, even if you have a supraclav also, then also it is a part of the limited stage. So anyway, I think moving forward, we need to get this clarity from the radiation oncology colleagues, whether they want to map, whether do they cover these lymph nodes in a limited stage, or they do
so Dr. Bhuvan, if it is PET positive, so I think many radiation oncologists are taking with the involved node if they are actually with the higher SUV, and if this is supraclavicular on the opposite side, I think then that may not be covered in as a limited stage.
Do you agree, Dr. Vashnay?
Yes, sir, I agree with that.
Okay.
Mostly, if lymph nodes are positive on PET CT scan, and further sampling is not needed.
Even in the non-smell, you do that?
Usually. I think there is a study from AIMS that is published, the EBUS comparison with PET CT, and they found that value is significant. There is no difference.
How much is the significant value? Because it's a general rule in my. I'll obviously take it up with my radiation oncology colleagues tomorrow.
Definitely.
But I don't think, because it's a common practice for us to generally map the, unless we're not talking about. So I understand if it's a large node, which is obviously definitely positive. We're talking about simply FDG EVIT nodes. Anyway, for a non-small cell, I'm certainly clear that only the FDG positivity. Obviously, the look of the node matters a lot. If there's a large node, you generally it's given that it will be positive. For a node which is around a centimeter, has a FDG avidity of, let's say, 3, 4, 5. I would rather have in a non-small at least, have a EBUS and define the radiation field, because I think the toxicity will change a lot with that.
I think, Dr. Bhuvan, you're right. I think cutoff is usually in our practice. We keep cutoff 7 to 8.
Yeah,
although sometimes nuclear medicine guys say this is SUV stupid uptake value. But still we take cutoff of 7 to 8. And you are right, if it is 3 or 4. So we have to take with a pinch of salt whether it is involved or not. So definitely I agree, we should go for some sort of sampling from that area.
And so moving forward, you obviously define them as limited stage and extensive stage. And so moving forward, the patient is a 62-year-old smoker. He obviously has liver positive, and the presence with increasing shortness of breath, hemoptysis, weight loss, and then there is a there's a massive enlargement of liver. It's an extensive stage disease. MRI is thankfully clear. And moving forward, so what is Dr. Jyoti? If you're there, you generally tend to prefer cisplatin or carboplatin for an extensive stage.
Hello. Hi, Dr.
Yeah.
Bhuvan.
Hi.
So your question is choice of platinum in EP regime, cisplatin. I try to give cisplatin because we all know that small cell carcinoma, it spreads to brain very fast, and cisplatin has some kind of penetration. So I prefer cisplatin if patient is eligible for cisplatin.
So your preference is for cisplatin.
Yeah.
Dr. Ankur, you have a particular fetish for either of the platinums, or it's primarily based on the general condition of the patient? Dr. Ankur, are you there? So Dr. Dini, what is your take on this? Choice of platinum?
Surely, Dr. Bhuvan, I think cisplatin will be my preferred choice, because if patient is having like some neuropathy because of diabetes, underlying diabetes or cardiac problem, and and obviously performance status, so there I may tend to choose carboplatin over this rather than using the cisplatin. Otherwise, cisplatin is my first choice.
Hello?
Yeah.
So sorry, I lost the contact. Sir, it's preferred is cisplatin only, but if I found general condition of the patient is not well, then I prefer carboplatin.
Why all of you saying preferred is cisplatin? I'm generally asking. There's a data to the contrary. It's both equal are there. I mean, when you consider an extensive stage disease, aren't both equal? Dr. Deni, would you want to? Why would you prefer cisplatin? I'm just really asking.
I think you're right, but like we have seen that for urinary bladder at least. So there is a data which says that cisplatin is better than carboplatin.
No, even for the limited stage, in a limited small cell, yes, cisplatin is obviously certainly better than carboplatin. But extensive stage, Dr. Ankur, do you think there is enough data to suggest both are equal, or?
Yeah, I feel the data is enough, but what we have followed in our clinical practice, I think update is still not there. And we prefer is because patient has to come ultimately for etoposide for 3 days.
So my thing is that if I'm giving carboplatin, I obviously, you end up preferring cisplatin for somebody who's fit. But my only thing towards carboplatin is it's easier to give, and then, you can tailor it more towards the kidney function. Because
I think, Dr. Bhuvan, we all have grown up with the understanding that cisplatin is slightly maybe better than carboplatin. You're right, in extensive stage it hardly matters, but our intention, there's a reflex action to use the cisplatin, and then you're right, you're not wrong in using the carboplatin.
No, I'm just being the
I got it. But reflexly, like there is no data as such, I think, but we think that cisplatin is better than carboplatin in outcome.
Number of cycles you generally stick to? You generally choose 6 or you choose 4? What's your standard practice?
So standard practice, like literature, 4 to 6. So I tend to use 6 cycle in my patients with extensive stage.
Dr. Vashne, what is your choice? 4 or 6?
So I usually prefer 6 cycle complete.
This is with IO, without IO?
This is without IO.
With IO?
With IO, 4 is my recommendation. So my trial is with 4 cycles only. So in that condition, we prefer 4 cycles. So
what I'm saying is, do you give into your? So obviously, once you small cell, once you've done 3 cycles, the patient responded very well. And do you give into your urge to do 3 more cycles, or you stop at 4th?
Sir, in case at least 4 cycle has to be given.
No, I'm 4 to de raha. I'm thinking, I'm asking you, do you go to 6 or you stop yourself at 4?
If a patient is not there for any immunotherapy, because ultimately the patient will relapse. So we are not opting any treatment. So we complete usually.
No, I'm talking about with IO. Sure, this is without
IO. With IO 4 cycles. With IO 4 cycles, and then we put on maintenance with IO.
Dr. Jyoti, with IO, your choice of cycles, 4 or 6? I think we lost her. Anyway, so I think we all understand that in today's world and era, I think if the patient can afford, I don't think anybody of us will not give immune checkpoint inhibitor unless it's contraindicated, and there's a good amount of data for it, and I think you don't obviously there are toxicities to it, but then considering that the patient has an extensive stage small cell lung where possibly any added therapy, so it's being called as a recalcitrant cancer, where there's hardly. So if you look at the DEVITA chapter, I think there are only 2 pages which says what works, and I think there are 4 pages which says what doesn't work. So I think obviously when with the IO coming in, I think it's obviously been some light in the end of the tunnel. And so in 2022, I don't think there's anybody of us who will not choose ETO, platinum, and IO. Dr. Ankur, would you choose otherwise, or that's your go-to regimen?
Sir, it's only depend upon the physician's status whether he is able to afford it or
We're
not.
obviously talking about somebody who can afford it. कोई नहीं afford
करेंगे.
So anyway, so I think there are 2 drugs to it. There's a durvalumab and there's a atezolizumab. Do you have any choice, Dr. Deni? Do you have any favorite as before we move forward?
Although data is almost similar, if you see the response rate and outcome. So both drugs have done very, very well, equivalent response rate and everything. But still, I have my intention to use durvalumab upfront rather than atezolizumab. So my experience with atezolizumab is not very good in terms of response rate. So I tend to use prefer to use durvalumab.
Dr. Jyoti, what is your choice of IO?
I think I agree with Dr. Deni that we have got a good response rate with both the drugs. There is no such preference. I am using both of them, atezolizumab also and durvalumab also. So both are equal for me.
Okay. So as we understand that, I think small cell, the problem is the rapid comeback, and as we move along the number of cycles, obviously the number of patients who receive the subsequent lines of therapy are very, very small. So both the drugs have been approved in the first line in a IO chemo combination. They both are given 3 weekly, and then there is the maintenance is 4 weekly for durvalumab, and it is 3 weekly for atezolizumab. And as pointed out by Dr. Varshney, both the regimens use 4 cycles of chemotherapy followed by maintenance IO. So as you see it, there are obviously 3 combinations which end up forming. There is ETO carb durva, ETO cis durva, and ETO carb atezo, which goes to say that in IM power 150 it was they could only use, there was no cisplatin given, it was only ETO carb and atezo. So I think the panel is clear that most of the time they end up using EP durva. However, there's an option to use EP atezo also. So just to give I'm sorry, it's not IM 150, it's a 133. So if you look at the difference of the study design, what was different was in the patient in the campaign arm, the PCI was allowed in the control arm, and PCI was allowed in the experimental arm. It was excluded in the experimental arm. The patients who underwent durvalumab, they did not receive PCI, and there was up to 6 cycles of chemo in the control arm they were allowed in the campaign arm, and also the cisplatin was allowed. So there were 3 essential difference in the campaign trial as compared to the IM power 133. The PCI, which was excluded so the patients were not allowed to undergo a prophylactic renal radiation. Up to 6 cycles of chemo in the control arm were allowed. They were not allowed in the atezolizumab trial, and the cisplatin was also allowed. So this is the difference at the end of. So what is also available is the 3-year follow-up data, which is obviously not available for the atezolizumab. So at the end of 2 years, there was an improvement of almost 9% in terms of overall survival, which I think, considering a small cell lung cancer, if somebody tells me that almost one out of the 4 is going to be living at the end of 2 years, I'll probably be happy. And possibly 17.6 or basically around 18% of the people are alive at the end of 3 years. And coming to the control arm, there's hardly, so possibly 6 out of 100 to 18 out of 100, which is a remarkable difference if we talk about the improvement in overall survival. So that's what has been there. So Influenza, which is the durvalumab, it's a well tolerable drug. It obviously improves the overall response, overall survival, and it's the absolute improvement may just be 12 months in the terms of median. But I think we all understand, and as I spoke in my last talk also. So whenever we're using IO, it's not about, it's possibly not about the median improvement. Yes, it does cause a median improvement in overall survival, but it is about picking up those patients which, so essentially we are talking about a disease in which there is no survival. Now, if you're able to pick up this extra subset of patients in which there is an extended improvement in overall survival, I think you have done your job, or possibly the drug has done its job. So as I told you, IMpower 133 at the end of 2 years, there's a data up till 2 years. There's a 22 months, 22% 2 year survival, and it's almost similar in the Caspian arm, Caspian trial. However, there's a 3 year data also. So I think same thing. So this patient receives systemic therapy, has 4 cycles of cis-eto durva, has near complete CR. There's a resolution of the liver lesion, which is obviously expected in the first line. He's put on maintenance durva, 4 weekly maintenance therapy, which is different from the 3 weekly therapy, which is given by atezolizumab, and it undergoes serial scans every 3 months. So, coming Dr. Vaishnav, do you do PCI for everybody, or you are taking a distinction in these today's world and era?
So routinely, what we studied earlier was that PCI has to be given in a patient who has responded. So now that with the data coming out durvalumab, where some patients were excluded, I usually discuss with the patient first.
I think not some, but then none of the patients in the durva arm underwent PCI. But yes, so Dr. Jyoti, your take on this? Do you routinely advise PCI? I lost Dr. Deni. It's the same thing. So basically, historically, PCI, as Dr. Vaishnav also commented, that historically, possibly everybody who had extensive stage small cell lung, we obviously wanted them to undergo PCI, because almost 90% of the patients, they did develop a brain metastasis, which possibly was more catastrophic. Now, however, the divergent data is there, and there's a prompt reassessment happening. There is availability of SRS, and we are obviously more aware about the adverse effect of a PCI. So I think it's a decision which needs to be individualized now. So as of now, the statement is there's a paucity of data as far as the integration of PCI and immunotherapy is concerned, and the patient with extensive stage small cell lung cancer without brain metastasis on MRI, I think PCI can be omitted, and a regular brain MRI may help you understand how do you want to go forward. So, Dr. Deni, your take on thoracic RT for us extensive stage small lung cancer.
So I think I can recollect only one of my patient in last few years only where I have gone for thoracic RT, because all the metastatic sites were clear, and I have gone for our radiation oncology. I have gone for PCI as well as thoracic RT. So many of the patients we are not opting for this thoracic RT, but if extra thoracic diseases are well controlled or in fact near CR sort of thing, then obviously we go for thoracic RT.
Which itself is very rare. So let's be very frank. It's obviously rare to
one out of 10, 20 patients. So, but yeah, I've gone for that in one of my patients.
So again, I think the statement is also very clear. There's greatest benefit of thoracic RT is limited to patients with residual thoracic disease after systemic therapy with less than or equal to 2 metastasis. And when it comes to immune checkpoint inhibitors, there's obviously a paucity of data. So, as we do more and more radiation so what I've started seeing is as we are utilizing more and more SBRTs for the oligometastatic sites, there are these systemic adverse effects which tend to happen. And, you think that you're doing possibly my radiation oncology colleagues thinks that he's doing a SBRT and there's going to be no systemic toxicity. What I've found is there's a lot of cytokine release, and most of these patients, they take a longer time to have for a myelo recovery to happen. I don't know, it's possibly my experience or somebody who's undergone a SBRT to a non-pelvic site also takes a longer time for a myelo recovery to happen, possibly because of cytokine release. There's a prolonged myelosuppression. So when you move on to the subsequent chemotherapies, they tend to have a longer side. The duration of cytopenias is longer, is what I felt. And I don't think any RT is without any systemic adverse effects. There is obviously some degree of systemic adverse effect is there, especially when you're using it with the agents such as gemcitabine or carboplatin, in which obviously there is the thrombocytopenia is a big problem with these agents, and I think that's where it kind of causes a problem. So again, coming to the NCCN guidelines, it does suggest that you can consider PCI and thoracic RT if the patient has extensive stage disease. But then, I think all these data are obviously the guidelines are derived from before the IO era. And I think coming to the IO era, we are very clear that somebody who has a PS 0 to 1 or equal to 2, you possibly may go ahead with Eto platinum with IO and for 4 cycles and followed by IO maintenance. So the patient is on DUVA maintenance as on surveillance for MRI brain. So again, if the patient had, Dr. Jyoti, let's say the patient had a brain metastasis diagnosis, do you consider or do you do SBRT for everybody to begin with, or it's only for the symptomatic brain metastasis? Do you end up doing SRS?
I prefer RT in patients who are symptomatic, like symptomatic brain mets.
I'm talking about asymptomatic. For asymptomatic ones?
No, I will go ahead with chemotherapy first, and if in any case patient becomes symptomatic in between, then radiation will be added. Otherwise, we'll finish off chemotherapy first.
Dr. Ankur, what is your take on it?
Sir, in asymptomatic patient, I prefer chemotherapy first.
And the reason being?
Usually,
are you not scared that the brain PD will happen?
Isolated, usually, sir, the disease is chemosensitive. They usually will respond. It's very rare to have a progression on chemotherapy.
Fair enough. I take your point, and also I think the other point to me is that possibly 2 weeks, even a week, 10 days delay in such a patient that leads to a rapid deterioration in performance status. Once the performance status deteriorates, you possibly lose that window where you can do Eto platinum.
Curative intent.
Anyway, so what was seen was the patient who had brain metastasis at baseline. There was obviously the overall survival was lesser, but the advantage of doing a Durva was more. So the hazard was it's 0.69 as compared to 0.74. Somebody who did not have brain metastasis, and as expected, obviously somebody who had a brain metastasis, the overall survival was lesser. But what is to be seen is that the advantage which possibly Durva is giving or IO is giving is better. So what has recently happened is that what has happened to me is so all these patients who tend to do poorly, for example, a triple negative breast who's PD-L1 negative, so there's obviously a definite advantage of doing immune checkpoint inhibitor, and they generally provide you a good advantage there. And that's what we've seen in a forest plot also, that somebody who had this is obviously the IM-Power 133, which I think there's the way this trial was designed, there's a bit of an issue with that. But then yes, the patient who had brain metastasis in which the placebo did better. And moving forward, the patient is on durvalumab maintenance, and after completed 8 cycles with no evidence of progression of serial scans. So what is obviously also different is that there is a once in 4 weeks maintenance with durvalumab as compared to once in 3 weeks. And I think we all have an answer for this. For somebody who is performance status 3 to 4, we end up doing best supportive care. And somebody, obviously the performance status does make a choice. Dr. Deni, would you choose irinotecan for somebody who has a poor performance status, or possibly any other agent other than the standard carbo Eto or cis Eto?
You're asking first line, no? First line
with a poor PS. No. Let's say the patient is poor PS2. Would you end up doing anything else?
No. In those scenarios, sometimes I have used weekly basis. So although it's 3 weekly is the standard platinum etoposide, but I have used weekly in some of the patient where poor PS is there, at least for 1 or 2 cycles, but not irinotecan.
Dr. Varshney, have you used? Sorry to interrupt, sir. Please.
Yeah.
Same, sir. I have used low dose carboplatin only, AUC2, and have seen improvement with this. Not use irinotecan.
Any biomarker you have evaluated in a small cell?
Not much experience regarding in this.
Anyway, so I think to summarize, we have, I think there's obviously, the IUs have become the standard line in terms of small cell. I think it's primarily because of the poor prognosis and poor biology this disease carries. It's obviously a nightmare to treat it. You will possibly have a very good response in the first 2-3 months, and then the way it comes back, it obviously breaks the heart of everybody. And I think moving forward, looking at the once in a month maintenance, which obviously Duva provides, it's obviously going to become the preferred agent or preferred IU when compared to adhesive. I think that's from my side. Thank you.
So Bhuvan, just one question to you. If extensive stage brain metastasis is asymptomatic, will you refer to radiation oncologist or not?
Extensive stage brain metastasis, single or multiple?
Asymptomatic brain metastasis, like we were discussing in.
No, I would not. But my point is, if there are more than 5-7, they'll do a whole brain RT. If there is a whole brain RT, the patient will never survive to come back to me. As in, after 3 weeks, 10 days of brain RT, a week, 10 days of waiting. After 2 to 3 weeks of a small cell, I don't think he will have a performance status to do anything. If it's a single odd brain met, anyway, I'll obviously prefer to give systemic therapy because it will take care of it. I think the only problem is if there are 3-4 of these brain metastases. That's the only thing which I'll be a little concerned about, especially if one of those brain metastases is it infratentorial or is it in a motor cortex where I feel like it may throw up. So that's the only problem, that's the only way I'll possibly have a discussion with the radiation oncologist as to this is a very critical area. It's just infratentorial. It may lead to some degree of it, possibly a discussion, but not a referral.
I think even for asymptomatic, we have to take them into loop before deciding not to go for radiation.
Agreed, sir.
Right.
Okay, sir.
So thank you, Dr. Bhuvan, for a wonderful discussion, highlighting the important points which we would think it's very easy, but certainly there are some points which we need to keep in mind before deciding the treatment plan of action for any malignancy for whatsoever. Thank you. Thank you.
Please.
So thank you all the panelists. So next